Well, thank you very much, Eileen, and thanks for the invitation to talk with your group today. Thanks to everybody who's attending. I appreciate it. My name is Chris McDougall. I'm the director of the Lurie, Lurie Center for Autism, which is owned by Massachusetts General Hospital. And I'm the Nancy Lurie Marks Professor of Psychiatry at Harvard Medical School. I'm a child and adult psychiatrist. The Lurie Center is the largest autism clinic in the world, and we treat people from birth to death. So one reason we're so large is we take care of adults until they're in the geriatric age. And as you know, there aren't many clinics or programs that even see adults with autism. And we're also multidisciplinary. So we don't think autism is just a brain disorder. We think it's a whole body disorder. And so we have primary care doctors, child and adult neurology, child and adult psychiatry, pediatric GI, developmental pediatrics, neuropsychology, speech, OT, PT, summer camps, job placements. And the good thing about our place is that we're all located in the same building. So families don't have to see multiple providers that have limited ability to communicate, if you know what I mean. We treat people from over 40 different states in the U.S. and over 25 different countries. So we like to see very complicated cases. And Eileen is going to help me with the slides today. Okay, so I'm going to talk about psychopharmacology because that's what I am a specialist in, but I certainly realize and appreciate that medication treatment is one part of the overall treatment plan. And I think of, as I've described, we believe in using everything that might work for a particular patient. We also have a number of individual therapists here. We have behavior therapy. We have educational consultants. So we try to cover every need that an individual may have. Next slide. These are some of the financial affiliations I have, if you will. So for a couple of companies, I've helped them design studies for medication trials. And then we've published some books on autism. One that I think is pretty good is called Primer, Primer, on autism spectrum disorder, published by Oxford University Press. Next slide. When we talk about medicines, we're always asked to state whether the medicines we're talking about are approved by the Food and Drug Administration for a particular purpose. And as you all probably know, there are only two medications that are FDA approved to treat any element of autism. And these are risperidone, which is Risperdal, or aripiprazole, which is Abilify. And these aren't approved to treat autism per se. They're only approved to treat irritability associated with autism, and only in children and adolescents. One thing that's important to know is there are no medications that have been shown to be effective for the core symptoms of autism, meaning social communication impairment and repetitive behavior. No drugs have been shown in placebo-controlled studies and where the study's been replicated to show any improvement in the core symptoms of autism. So everything we're treating with medicine is what I would call an associated symptom of autism. And that doesn't minimize its importance. We all know that if we can reduce hyperactivity and aggression and self-injury and help with sleep, that can improve the quality of life of many of these individuals. Next slide. The goals of the talk are really to talk about these associated target symptoms that might improve with medicine, to talk about which medicines we use for which target symptoms, and to talk about side effects associated with those medicines. Next slide. These are what we call target symptom domains, and I'm going to go through each of these. And let me talk a little bit about motor hyperactivity and inattention. We often think of that as ADHD, right? And it's interesting that in DSM-4, we weren't allowed to diagnose ADHD if a patient was diagnosed with what was called back then a pervasive developmental disorder, now called autism spectrum disorder. We weren't supposed to do that. It was almost like if they had hyperactivity and inattention, that was part of the autism. Well, with DSM-5, which has now been around for 10 years, believe it or not, you're all of a sudden we're allowed to diagnose ADHD if with the and ASD. So that's make of that what you will. I think it's kind of a silly thing. But let's start talking about the medicines we use to treat ADHD symptoms and autism. Next slide. So we really use the same medicines to treat comorbid ADHD that physicians would use to treat ADHD in a more neurotypical population. However, the response to these drugs is quite different in ASD than it is in ADHD alone. So this is somewhat important to listen to. Next slide. So we all know that the first line drug for treating ADHD, if you're going to use a drug, is a psychostimulant. And there are really two categories of psychostimulants. There's the Ritalin or methylphenidate-based group, and then there's the amphetamine-based group. And they're different. If one group, you try one group and it's not helpful or it causes too many side effects, then you should try the other column because it may, in fact, help. Now, in kids with ADHD alone, these drugs work 70 to 75% of the time. They're very effective. In autism, they only work about 25% of the time, and there are a lot more side effects and people that can't tolerate the drug. So maybe that suggests that ADHD alone and ADHD and ASD have different underlying biologies, if you will. Next slide. So beginning in 1997, the NIH funded a group of a network really of sites to collaborate on medication studies in autism. And it was called RUP, Research Units on Pediatric Psychopharmacology. And it was, there was a site at the Yale Child Study Center, Indiana, where I had moved to, Hopkins, UCLA, and Ohio State. And one of the first studies we did was, let's see, in fact, what happens when we try to treat ADHD and ASD with a first-line drug treatment for ADHD, which in this case was generic Ritalin or methylphenidate. Now, as clinicians, we already knew that many of these kids were not going to tolerate a stimulant. They were going to get worse. We knew that clinically. So we first had a 1-week test dose phase. So here's 1 week, and every subject received 1 day of placebo and 2 days each of ascending doses of methylphenidate, low, medium, and high, because we wanted to see, and it was done in a blinded manner so that nobody knew what they were getting. We wanted to see if you're going to get worse after a dose or two of drug, we're not going to enroll you in a study. Why? That wouldn't make any sense. So after that 1 week phase in 72 kids, 6 of the subjects dropped out because they couldn't tolerate the medication. The 66 kids that survived, who were about 8 years old or so, they then entered this 4-week phase, 1 week, 2 week, 3 weeks, 4 weeks. And each week, the subjects they could receive placebo the whole week, or these 3 different doses of methylphenidate, and the order was all mixed up, and we didn't know what they were getting, and they didn't know, so double blind. And because you could say, well, how could you know in 1 week if a certain dose of a drug is going to work or not? Well, that's just the way it is with stimulants. They can work quickly. You don't have to build up the dose per se. So they were long enough to see. And in this 4-week phase, 8 more subjects dropped out due to side effects. That doesn't mean they got side effects. It's the side effects were so severe they dropped out of the study. Next slide. So 58 of the 66 subjects were still in standing, if you will, after the 4-week phase. And now we're up to something like 13 or 14 that have dropped out due to increased irritability. They got worse with just a very little amount of methylphenidate. However, when we looked at the effect of the drug versus placebo, it was more effective for ADHD than placebo, as rated by both teachers and parents. But let's talk now about, well, maybe more effective, but how was that relative to what you would see in ADHD alone? Next slide. So 44 subjects, again, remember there were 72 initially, got better with one of those weeks of something, but in 9 out of 44 cases, it was to the placebo week. So there was a fair placebo response. And when we look to see which subjects got better, like was there a clinical feature that was associated with response? You know, going in as clinicians, we thought the younger you are, the more autistic you are, if you will, the lower your IQ, the lower the chance of getting better. Younger kids weren't going to do as well. More classically autistic kids with cognitive impairment weren't going to do as well. And the sample wasn't large enough to sort of sort that out with certainty, but there was a trend to suggest that the higher functioning, if you will, individuals with Asperger's or PDD-NOS did better than more classically autistic people. And the way I think about that in a simple way is, if you have Asperger's disorder, you're closer to normal, your brain is, to a more typical person with ADHD than if you have autism and ADHD. But the response, as I mentioned earlier, you know, maybe a third of people got better instead of 70% if it was straight up ADHD. So next slide. Okay, the take home point there is, you know, stimulants are not what we use first line by any means, because a lot of these patients are going to get worse. And if they've been waiting for a year and a half or 2 to see me or you, and I start a drug and they get worse after 2 doses, that's not going to get us off to a very good start. So don't think stimulant as the first line treatment for ADHD in ASD. Well, if the first line drug doesn't work well, and the first line drug is what people are going to be using in the community for ADHD, what do? Well, we try non-stimulant treatments, and one of those is atomoxetine, which is called Strattera. And atomoxetine is FDA approved for the treatment of ADHD in children, adolescents, and adults. And you understand how Prozac works. It works by increasing brain serotonin. It's a selective serotonin reuptake inhibitor. Atomoxetine is a selective norepinephrine reuptake inhibitor. It increases brain norepinephrine. That's what it does. And many psychiatrists in the community would say, you know, it's not very helpful for ADHD in general. We like stimulants. Well, I just told you that stimulants don't work so well in our world. So maybe atomoxetine actually works better in our population. Next slide. So this was an 8-week study of atomoxetine or placebo, 100 subjects, they're kids, 9 or 10 years of age. You know, in general, the IQ was greater than 60. They were a somewhat more high functioning group, which you might think might be better tolerate the drug. And the primary outcome measure was the one that's used in standard ADHD drug studies, the ADHD rating scale. Next slide. And if you look at this table sort of in columns and you see ATX or atomoxetine, and you go down the column, you see that before the drug, the score was 40.7, and after the 8 weeks, it was 31.6. So it dropped on the total rating scale score. And if you look at the subscales for inattention and hyperactivity, it also showed improvement, but it looks like the drug was better for hyperactivity than it was for inattention. And in fact, that's true. Next slide. What about side effects? There really weren't a lot. There aren't a lot of side effects with atomoxetine, mainly GI related. And if you start the drug at a low dose, I always started at 10 milligrams, which is the lowest possible dose. And you go up at a reasonably slow rate, like 10 milligrams per week as tolerated, you're not going to see many side effects. You're not going to see behavioral worsening like you would with a stimulant. Next slide. So, you know, atomoxetine probably works 50% of the time, in my opinion, when we use it, versus a stimulant that might work 25 or 33% of the time. What's another drug to treat ADHD? Another non-stimulant treatment, an alpha-2 agonist. Next slide. You know about these drugs. One's called guanfacine, one's called clonidine. The long-acting form of guanfacine is called Intuniv. And you could use guanfacine or clonidine. We tend to use guanfacine because clonidine is more sedating. It might cause too much sleepiness during the school day. So we tend to use guanfacine. It's not as sedating. And in this study, again, by the Rupp group, 62 kids with ASD and prominent ADHD, 8 weeks, drug or placebo, same design. Next slide. If we look at the XRG, extended release guanfacine, or Intuniv group, 30 kids, there was a 43% drop in ADHD symptoms. And in the placebo group, there was only a 13% drop. So that's a big difference. Next slide. If we look at response to the drug, extended release guanfacine, 50% of the patients were much better, very much improved, and placebo only 9%. So again, that's a big difference. The drug was quite helpful. Now, how do you dose this? It comes in 1, 2, 3, or 4 milligrams. It's not complicated. It's a once a day in the morning drug. So you would start with 1 milligram in the morning, and you might go for a week or two. And if there's not significant improvement, you go up to 2, 3, 4 as needed. In this study, the sort of modal final average dose was 3 milligrams. Next slide. What about side effects with guanfacine? Well, it can be sedating. It can cause you to feel sleepy. And you just simply, the sedation will usually wear off. You just don't go up on the dose until that happens. The goal isn't to treat them by making them sedated, but you might see some sedation that's transient along the way. These drugs, in the old days were also used to treat high blood pressure. That's what they were originally for. So you could say, well, wow, what if you lower the blood pressure in these kids? Well, we looked at that, right? And during the study, the blood pressure did drop a little bit during the trial, but by the end of the 8 weeks, it was back to baseline. It wasn't dangerous. If you look at heart rate, it actually dropped by 10 beats per minute and stayed down. But remember, these were kids who were drug-free before the study, hyperactive ASD. Their heart rate was abnormally elevated. So in many ways, it simply normalized. Mentioning that this drug is used to treat high blood pressure, you might worry about the heart. You might worry about the EKG. There were no changes on EKG with the drug treatment. And again, I would say overall, this drug works about 50% of the time, similar to atomoxetine, better than a stimulant. The other thing that's important to know about the alpha-2 agonists here, they can cause constipation. And as many of you know, GI problems, including constipation, are quite common in people with ASD. 25 to 50% may have that. And, you know, if you cause significant constipation and you don't know it, it's going to lead to behavioral problems. And you don't want to attribute that to psychiatric symptoms if it, in fact, there's an underlying medical problem. So very important to know about. Next slide. So we're done with ADHD. Our order would be guanfacine, atomoxetine, stimulant. What about irritability? So if you remember, that's what the FDA has approved risperidone and aripiprazole to treat, irritability. That's it. That's the only approved treatment for anything related to autism. And the way I think about irritability, it's aggression, self-injury, severe mood swings, tantruming, that kind of thing. And that's, in fact, what I enjoy treating the most, because I like to treat people who are really impaired, because it gives me a lot of room to get them better, if you will. And, you know, treating severe aggression or self-injury, especially in adults, can be really improve their quality of life and help keep them placed in, you know, the least restrictive setting. So next slide. When we think about the treatment of irritability, we think about antipsychotics and we think about mood stabilizers. Next slide. Let's start with antipsychotics. Next slide. Because again, only antipsychotics are FDA approved to study this and showed it to work. You know, there are these atypical antipsychotics, right, that have been around now for, what, 25 years, 30 years. They're not new anymore. You've heard of many of them. I'll mention the trade name: Risperdal, Abilify, Zyprexa, Seroquel, Geodon, etc. And, you know, the main side effect that we've encountered with these drugs is increased appetite and weight gain, right? Which can be substantial. And if you gain a lot of weight, you're now put at risk for a lot of other medical problems like high blood pressure, diabetes, metabolic syndrome, stress on your joints. And, you know, if you gain a lot of weight, it's hard to lose it. But unfortunately, every one of these drugs can cause substantial weight gain other than ziprasidone or Geodon, which usually doesn't, although it can. However, Geodon hasn't been studied in an adequate way to look at its potential effects for irritability. Next slide. So back to the RUP network, the first study we actually did was of risperidone for irritability in kids with autism. Next slide. 101 kids, classic autism, not high functioning, whatever. They were very irritable, drug-free, 8 weeks, drug or placebo, 9 years of age. The final average dose of risperidone at the end of the study was 1.8 milligrams per day. Now, you can use up to 30 milligrams a day. I mean, it's approved. But remember, this drug is often used to treat schizophrenia or bipolar disorder. And we use much lower doses in kids with autism or adults. I never, ever use a dose greater than 4 milligrams. It won't help if it isn't helping by then. And 4 would be high. I might start a dose of 0.25 milligrams or 0.5 milligrams once or twice a day and go up as needed. Next slide. Here you see Risperidone, 70% of the patients that got risperidone were better. That's pretty good, talking about severe aggression and self-injury. 12% got better with placebo. So again, it's a big difference. Next slide. I often say this: drugs that don't have side effects don't work. You know, the world wants naturalistic products to treat symptoms. Well, that's sometimes helpful. But in self-injury, aggression, or psychosis, drugs that don't have side effects will not work. If you have powerful symptoms, you need a powerful drug to treat them. That's just the way it is. So this drug's going to have side effects. Again, one of the prominent side effects is increased appetite and weight gain. And, you know, if you have food can often be used as a reward for some people with ASD, right? If you behave right, we'll give you a snack, whatever. Well, if you're doing that, their appetite is going to be unsatisfiable. And they're going to keep wanting food, and now you're going to start denying food, and you're going to see an increase in aggression. So it can get you into a bad cycle. This drug can also cause you to be a little bit sedated, which is not bad when you're treating irritability, because it will wear off. The good news is that, at least in the short study, we didn't see the development of any abnormal motor movements like tardive dyskinesia. Now, certainly, any of these atypical antipsychotics can cause tardive dyskinesia, just like the older drugs like Haldol. So we need to be mindful of that and monitor for that. Next slide. Okay, here's the other one that's FDA approved, aripiprazole or Abilify. You know, this is a big study, 218 kids, same design, 8 weeks, drug or placebo. And aripiprazole was better than placebo, again, for irritability. The drugs are different. Which one's better? It depends on the individual. I think with either drug, you will have at least a 50% chance of the patient getting better. And the thing about these drugs is they work fast. It's not like Prozac or Zoloft where you have to increase the dose gradually. These drugs can work within a day or two. And that's really important when you're trying to treat acute impairing symptoms. These drugs can help keep a patient out of the hospital because they can work quickly. And as we all know, we want to try to keep people out of the hospital because they can only stay for a little limited period of time. There isn't enough time to change the medicine safely. So to try and avoid all of that time and headache and paperwork and expense is what we try to do if we can. There aren't any beds anyway, right? You're going to be in an ER for 3 weeks, and after a day in the ER, your symptoms are going to be better, and they're going to discharge you home, but you're going to be back a week later. So anyway, next slide. What about mood stabilizers for irritability? You know, some of you were taught that the classical mood stabilizers are lithium, Tegretol, and Depakote. And those drugs are all safer than an antipsychotic. The problem is they don't work for irritability and ASD the way that atypical antipsychotics do. And the studies of these drugs for irritability and ASD haven't found them to be particularly helpful. So we generally don't use them. If I've got a patient where I've got more time based on acuity, I might try 1 or 2 of these because they are safer than the atypicals. But usually there's some sense of urgency in trying to treat severe aggression and self-injury. Next slide. That's what I just told you. Next slide. What about repetitive thoughts and behaviors? Well, we could talk about this for a week. I was at Yale before I was at Harvard, and there's Dr. Volkmar. Dr. Volkmar was one of the my main mentor when I was at Yale. You know, Dr. Volkmar is a world leader in autism, and he used to be mentored by a man named Donald Cohen, who was a world leader in child psychiatry. And I was fortunate enough to be trained by those gentlemen. But before, Fred knows, before I did autism, I was doing adult OCD. And then I discovered autism and became fascinated by it. And in part, it was because of the repetitive behavior that you see in both disorders. So one thing I can tell you with some certainty is the repetitive behavior of autism is not OCD. Now, the parents are going to come to you and say, my child has OCD. And you're going to say, I know what you mean, but let me change your terminology. Let's call it preoccupations for repetitive thoughts, not obsessions. Let's call it repetitive behavior of autism, not compulsions. And you could say that's semantics, but not really, because the only drug that works to treat true OCD is an SSRI. And SSRIs for the repetitive behavior of autism are not very helpful. And in fact, they often cause behavioral activation and worsening. So if you said to me, well, you probably use a lot of SSRIs in your world, right? I'd say hardly ever. Really? That's correct. Now, you may have a different experience, but I don't. Next slide. So next slide. There have been some pretty large studies of SSRIs versus placebo to look at repetitive behavior in autism. And here's sort of what we got. This is one we did years ago with Dr. Volkmar and kids with autism, 10 years old. Fluvoxamine is FDA approved for the treatment of children with OCD and adults. And we went into the study thinking it might cause some behavioral activation. So we started very low and went up slowly, but only 1 out of 18 kids that got the drug was better. 1 out of 18. And if this was OCD, it would have been 60%. And look at the kind of side effects we saw: increased insomnia, hyperactivity, agitation, not what you want. So next slide. There have been subsequent studies, larger studies. This to me is the classic one: 150 kids, 12 weeks, drug or placebo, very good investigators, Brian King and others. Citalopram, they had a different SSRI, no drug placebo difference, and a lot of behavioral worsening. Next slide. One more example. Let's look at fluoxetine for the same reason. 14 weeks, 158 subjects. It didn't work, and it made kids worse. Next slide. All right, what about sleep? Well, 40 to 60% of people with autism have prominent sleep disturbances. And you could say, that's not a big deal. Well, it is a big deal. If they don't sleep well, their behavior is not going to be very good the next day. The siblings that are awake all night, their behavior is not going to be very much good the next day. And the 10-year-old kids sleeping with mom and dad. So everybody's going to be affected. So let's go to the next slide. Next slide. So there really haven't been very many quality studies of medicine for sleep, which is a shame. The only controlled studies are with melatonin, and that's been like 15 studies. Okay, we know that it can work better than placebo, but it's kind of a lightweight drug. I mean, you want to start with it because of its safety, but the kind of people that I see, Dr. Volkmar sees, many of you see, they had melatonin a long time ago, and it didn't help. So what are we going to do? Well, the other drugs that we use, trazodone or Deseril, clonidine, mirtazapine, which is called Remeron. It's an old antidepressant. I've begun to use this drug called Zolpidem or Ambien for refractory sleep disturbances and have pretty good success. But there really isn't any data to guide our treatment of sleep beyond melatonin. Next slide. What about mood disorders? Next slide. Well, we use antidepressants and mood stabilizers, right? Next slide. This is really remarkable to me. There is no published placebo-controlled study of any drug for the treatment of depression and autism. That means any age, any subtype, any IQ. There's no drug study of treating depression in the world literature in autism. Now you would all say, well, don't they get depressed? And we'd say, well, sure they do, right? Uh, it's sometimes hard to diagnose it. If you have a person with autism who is minimally verbal, and you say to them, how do you feel? They're like, if they say something, they might say hungry. They have difficulty identifying and communicating the way they feel and the way we like to understand it. And when we treat depression or anxiety, we like the person to say, I feel sad, depressed, nervous, worried. You can't get that. You can get that in some of the higher functioning folks, and we treat depression often, but there's absolutely no guidance on treating depression in ASD. Next slide. There's no studies of bipolar disorder in ASD. I mean, big studies, because I don't think bipolar disorder is any more common in them than it is in us. And although it's probably overdiagnosed, because there's a lot of cyclical irritability and mood lability, it may not be bipolar disorder, right? One thing I use at times to try to get a sense of it might be bipolar disorder is to try to get a good family history, but we all know, if you ask parents, do you have a family history of bipolar disorder? They'll say yes. But what they might mean is just recurrent major depression. We think we want an answer based on our knowledge base, and they may not have that. The other thing I'll sometimes say is, anybody in your family ever been treated with lithium? Because that's kind of the classic treatment. If somebody's been on lithium, there's a pretty good chance they may have had bipolar disorder. But there are no studies of bipolar disorder in autism in the literature. Next slide. What about anxiety? Next slide. Next slide. All right. I think Dr. Volkmar would agree. He's a deeper thinker than I am. He's from the Midwest too. I was going to say I'm from the Midwest. I'm from Indiana. He's from Illinois. And but I tend to think about things in a kind of simplistic way. And when I think about autism, these are people that thrive with predictability and certainty, and they struggle with uncertainty. And most of the world is uncertain, not predictable, and that causes anxiety. And I think it took the field a while to be able to diagnose anxiety in autism, because we might see a patient with autism and anxiety, and we say to the parents, I think he has anxiety. And they're like, what are you talking about? Why? Well, he's pacing. He's scripting, right? He's pacing and talking about a recurrent Disney theme in his head. He has increased stereotypic behavior. He's biting at or picking his fingernails. That's a very good sign of anxiety. He has a sleep disturbance. He has great difficulty with transition from the home to the bus to the school. Why? Uncertainty, a different school bus driver, different kids, a different route. All of that stuff causes anxiety. The original description of autism talked about insistence on sameness. They want sameness. That's why they do things in a repetitive way. They line things up. They restore. It's not OCD. It's an effort to restore sameness. So if it was any of us going to the doctor for anxiety, if they were going to use a drug, they'd probably start us on an SSRI. Well, I just told you what happens with SSRIs in autism. So we quickly figured out that's not going to be a way to go. And we've settled on using two drugs that are really old drugs. And most of the psychiatrists on the call would say, McDougall, you use buspirone or Buspar. Don't you know that doesn't work? That's an old drug, man. I'd say, well, it doesn't work for you or me, but it works for these guys. And SSRIs work for you and me, but not for them. Their brains are different. Next slide. So again, not great studies even with Buspar and anxiety, but clinically, I feel it works 60% of the time. And this is a study, but one of Fred and my colleagues over in the Netherlands, Butelaar, who's a good man, and they found that it worked quite well. Moderate benefit or marked benefit in a number of people with autism. So it's a pretty good, very well tolerated, very few side effects. Next slide. The other drug we often use for anxiety is called mirtazapine, which is Remeron. It's from the 80s again. It was to treat major depression in adults, but we found that it caused them to be too sleepy. So it fell out of favor. Well, I had to look for other things to use if I didn't have SSRIs. And I started looking at this for anxiety and autism. And actually, this is the only published placebo-controlled study of any drug to treat anxiety in the world literature. And we did it, and it was 2022. And it's not even a good study. I mean, it's a small good study, but it's not large. It doesn't have the power. But it suggested that mirtazapine is better than placebo for anxiety. Now, a little bit about mirtazapine. The typical starting dose is 15 milligrams for you or me, and the maximum dose is 45. Now, listen carefully. The starting dose in my world is 3.75 milligrams. So I prescribe a 7.5 and give half. That's really low dose, but it's just what works. And we give it all at bedtime. Why? Because it can be somewhat sedating. Fortunately, many people with anxiety also have trouble with sleep. So it can help with two things. And we go up by 3.75 milligrams a week until they're better. The main side effect to watch for is the possibility of some increased appetite, although it's not as common as with some of the other meds we talked about. So I would encourage you, if you're a prescriber, to try to make some diagnoses of anxiety in autism. Do your best. It's not easy. And try buspirone or mirtazapine. You might find that it can be a helpful, safe drug. Next slide. This is just showing there aren't any studies of SSRIs for anxiety that have shown any benefit. So there you go. Next slide. All right. Now, I told you at the beginning of the talk, there aren't any drugs that have been shown to help with the core symptoms of autism: social impairment, language impairment, repetitive behavior, which is a shame, but maybe a reality, which is why early intervention, non-drug approaches are so critically important. Let's see what we have tried for these symptoms. Well, look at that list. This goes back, right, Fred, to the late 70s and 80s with Magda Campbell and a lot of other people. These are drugs that affect all the different neurochemical systems: serotonin, dopamine, opioid, glutamate, etc. So people have really danced around to try to find the right chemical to treat, but none of these drugs have shown to be helpful for social or communicative impairment. None of them. And a lot of drug companies have tried to find the drug, and they're out of business. Okay, they're out of business because they might find that a drug helps improve social behavior, let's say in an animal model of Fragile X syndrome, and everybody's excited, and there's an article on the front page of the New York Times, right, Fred? Disease modifying drug. Now, one of the things Donald Cohen taught me years ago, he says, you never want to be on the front page of the New York Times. He actually said that to me. And that's a good thing. You do not want to be on the front page. And so sometimes there's a hype that gets parents excited, and it's a shame. There's not going to be any quick breakthrough with a drug in the treatment of these symptoms. Next slide. The one thing to follow a little bit, but maybe not too carefully, is this thing called folinic acid. And you can actually prescribe it. It's called leucovorin. And it's used in the treatment of cancer a little bit. It's very safe. People have studied it in a placebo-controlled way to look at its effects on expressive language in very young kids with autism. And there's actually a proposed biological mechanism that makes sense. It may not be true, but there's a logic to it. And we've been involved with studies with this drug, controlled studies. It seems to me that some of these kids have shown some improvement in aspects of expressive language, but you're also they're having ongoing development as a young child during a 12-week trial. But it's safe. It's easy to prescribe. You could consider, there's not a lot of downside to trying it. But anyway, follow it, but don't be overly enthusiastic. Next slide. This just shows you again, the point of this is our multidisciplinary approach. All these people are different kind of psychologists or psychiatrists and child or adult. And again, the other thing about us is across the lifespan, which I think is really important and useful for parents. Next slide. This is my email address. Now, all I do is work. I don't have a personal life, so I get bored. I want you to email me, and I'm happy to try to answer a question. Hey, McDougall, send me an article on this or that. I'd also like you to ask me a question about the Beatles. That would get interested. Like, hey, what was John Lennon's first wife's maiden name, or something kind of tricky, because I'll know the answer. I'm a big Beatles trivia guy. But that's kind of that. So where are we, Eileen? We could take questions, however you want to manage that.
Yeah, we've had a
Great talk.
few questions.
Let me apologize. The only trouble, with Zoom these days is when the internet goes out, the Zoom doesn't work.
Oh my God, yes.
So I apologize, but I was happy to be on. Great talk as always. And Eileen, do you want to do some of the questions?
Yeah, sure. So we have a few questions. I'm just going to start from the beginning. We had one person she said, I'm wondering about, and excuse me if I pronounce these incorrectly, I am not a medical professional, VILAR, and more generally about using results of DNA testing like Genomind to guide medication choices.
Okay, I'll talk about that. Parents often bring up to me, hey, should we get this genetic test? Would you order it? Because it'll tell us how my child metabolizes drugs. It'll tell us which drugs are going to be well tolerated and might work and which won't. I don't think that's true. I think that's at this point in time, a big money maker for somebody. And they're like, well, wouldn't it help you guide what you do? And I said, no. What guides what I do is my clinical training and my experience. It makes sense that they want that, but I would, and if they want to get it, I'll order it. But I will tell them it's not going to be something that's going to guide my treatment. So sometimes we think fancy things are really important, and sometimes they're just not. So that's what I would say.
Next question was regarding repetitive behaviors. Dr. Nicholson wants to know what does work for repetitive behaviors in ASD.
Well, that's a good question. So I don't know. The way I think about repetitive behavior in autism, if an individual is kind of flopping their hands, they're trying to self-regulate me, right? Their feeling state is not baseline. They're either really happy or really sad. You may not know why they're flopping, but they're experiencing something that's not typical, and they're trying to deal with it. So we don't want to necessarily view the repetitive behavior of autism as a pathological comorbidity. In fact, it's a core symptom. It's there for a reason. If they don't have it, you can't even diagnose it, right? So the point here is, don't think about it like an comorbid symptom or diagnosis like OCD. It's just part of the syndrome that we haven't been able to help. But maybe we're not gonna help because we're not supposed to. Now, can it become interfering? Well, if you have repetitive self-injury to the same spot over and over, sure. But there you're going to be using a drug to treat irritability, self-injury, aggression. we're not going to really go after the comorbid repetitive behavior that's typical of autism. Why does a guy sit in a corner and spin something over and over? Well, the outcome is very predictable. He knows what it's going to happen when he does that. In fact, they can get very good at some of these stereotypic behaviors. So try to think about it as potentially their effort to adapt rather than something to try to eliminate. I'll just say that.
Okay, next question. I work with a young man who is diagnosed with Down syndrome, ADHD, autism, and intellectual disability. He's been prescribed clonidine since childhood for sleep disturbance. He has become morbidly obese and diabetic. Could this be playing a part in it?
What was the very last thing you said?
Could the clonidine be playing a part in this?
Okay. Well, I know a lot about Down syndrome in my personal life and my professional life. So we actually have a very large Down syndrome clinic at the Lurie Center. We also have a very large Williams syndrome clinic and Angelman syndrome clinic. And I feel like we have the top psychopharmacology approach for Down syndrome in the world because we do a lot of it across the lifespan. You know, Down syndrome, you're going to see a lot of comorbid medical problems, hypothyroidism, obesity, that's the way, sleep apnea, etc. And you have to think about those medical problems when you choose a drug. You don't want to make those things worse if you don't have to. The other thing I'll say, though, the treatment of depression, for example, in Down syndrome is pathetic. Because people like to say, well, they're retarded, you know, that they don't get depressed or whatever their silly thoughts might be. So there's very limited research on treating depression and Down syndrome, and these people can become profoundly depressed. It's sick. So that's one thing. Clonidine very rarely is associated with weight gain, almost never. So it's probably either weight gain associated with the course of that person's development or reduced motivation to exercise, right? It may not be rewarding. It's not easy for them. And again, I think sometimes people get caught up in using foods as a reward. You know, we feel their life is empty. They really like a certain food. It's not good for your body, but we give it. So I think it's probably more environmental or just part of the medical course of the syndrome, not the clonidine. Give me more, Eileen.
Yep, sorry, I was muted. So a couple questions. First off, has there been any research done on the effectiveness of weighted blankets with AD?
Yeah, there's probably been some research. You know, I don't know any research, but I will tell you clinically, that's not a bad approach. You know, some people with autism, well, we know sensory issues are a big deal. They can be hypo-responsive to the different sensory domains, hyper-responsive. They can be sensory seeking or avoidant. But sensory weighted blankets can help some people feel more stable, more in control. I don't see anything wrong with them as a general statement, but I'm not aware of research. Clinically, they can be helpful at times.
Good. The next question was modafinil is used off-label for ADHD. Is it also used in autism?
Yeah, so modafinil, you know, or Provigil is generally used to treat sedation that's secondary to sleep apnea. So if you're not sleeping well at night due to sleep apnea and you're tired during the day, it's used to give you a little bit of a lift, right? That's what it's FDA approved for. It can also be effective in ADHD. It's not FDA approved for ADHD, and you might run into a little trouble with like the insurance company. They're probably going to say, well, did you try this, and this first? But it can be effective. I wouldn't say more effective than a stimulant, for example, but it could be effective. Yeah.
The next question is regarding a higher functioning ASD, Asperger's, and the lack of medications. So they wanted to know how you approach ADHD meds in that subgroup. Do you trial a stimulant first, giving more patients in the group respond, or do you start with guanfacine?
Yeah, very good question. So as I kind of said, and again, it's a simplistic way of thinking, but sometimes that's okay. The higher functioning you are with autism, the closer to neurotypical your brain is. That just me. So the more neurotypical like your response might be to a drug. And so a stimulant is going to be better tolerated in a person with a more typical IQ and a more normal, more typical verbal language ability. And, the good thing about a stimulant is you're going to find out if it's going to help or not very quickly. He's either going to get better or get worse within a week. And you could say to me, why would I mess around with 4 weeks of atomoxetine and 4 weeks of Intuniv when I might score with a few days of a stimulant? Well, I think that's a reasonable argument, particularly in the higher functioning group where the likelihood of tolerability is better. So I think that's a very reasonable thing to consider.
Thank you. Next is regarding young adults in late 20s and early 30s, and how well do antipsychotics like Abilify work for this group, and especially ASD having profile and self-injurious repetitive behaviors?
Yeah. So, when I started doing autism, I wasn't a child psychiatrist. I hadn't really engaged with Dr. Volkmar yet. But I wanted to do autism. So I started a clinic for adults with autism in like the late 80s. Well, there was no such thing as adults with autism in the late 80s, remember, except Rain Man. So they came from all over the country, man. And I didn't have an idea what I was doing. I just wanted to do it and sort of learn from them. But the point of that is a couple of my first studies were in adults with autism. And one was risperidone, and it worked for irritability just as well as it works in kids. So I don't see any difference in the response to antipsychotics for irritability in between adults and kids. What was the last part? Yeah, one of the problems in the studies of risperidone for autism is we say it works for irritability. And then they'll say, well, what do you mean? Do you mean aggression toward others, property destruction, or self-injury? And we're like, I don't know. We grouped it all together. It was a total score. So we don't have great information on what works for self-injury in particular. I will tell you from my clinical experience that risperidone and other atypicals can be helpful. The one not to forget about that old people know about, old doctors, is a drug called naltrexone. And, many of the studies say naltrexone does not work for self-injury in autism. That's not necessarily true at the individual level. Naltrexone is very safe, so much safer than an antipsychotic. I start with 25 milligrams a day. I might go for 2 weeks. I increase by 25 milligrams every 2 weeks, maximum dose 100. It's a reasonable thing to try naltrexone for severe self-injury. Maybe 25 or 33% of the time, you're going to be like, oh my gosh, that was really helpful. And, then you avoid a lot of the side effects of the more powerful drug, but just something to put in the back of your mind or the front.
So we have a few more questions left, but it is 10 o'clock. So I didn't know if you wanted to continue answering them.
I can do all day. I can do all day for you guys.
All right. So there's only, I think it's 3 or 4 questions left. That's it. Next one, I find this one interesting. This person's asking, with a unique medication response specifically from Asperger patients, what are your thoughts on the recent change in the autism spectrum definition in the DSM?
Well, that's Dr. Volkmar's primary area of interest in the way I think. And I think he and I think along similar lines. And Dr. Volkmar was really, in my opinion, responsible for the diagnostic criteria in DSM-4. And in my opinion, DSM-4 is still the most appropriate, accurate way to think about the diagnosis of autism. In fact, I still use DSM-4 criteria when I make a formal diagnosis in a report, Fred. I have Axis 1, Axis 2, Axis 3, Axis 4, Axis 5. And there's something meaningful about the diagnosis of Asperger's disorder. I mean, Fred's approach was to say, look, IQ and language ability are really important in diagnosing ASD and separating it out into subtypes. That's just a no-brainer. And instead, the DSM-5 committee said, we want to change it. We want to say everybody has the same diagnosis, whether you go to MIT, whether you're nonverbal and cognitively impaired and have seizures, you get the same diagnosis. There's no other option. It's ASD. Well, try to do research there. Like, well, we're going to enroll people with ASD. Well, what do you mean? High functioning, low functioning? You didn't have to worry about any of that with DSM-4. And what about the patients who were diagnosed with Asperger's or their families? We finally figured out what we've got. And the patients themselves, I know what I have. It explains it. I have people like me I talk to. That's all gone, man. You're like, oh, you can't say that anymore. It doesn't exist. So I think you might have a sense of how I feel about that. I think it was a big step backward. What are the pros about ASD and DSM? It allows some people to get more services. It's easier to get that umbrella diagnosis. Those people do have problems. I think it's okay. We can still deal with their problems but trying to diagnose them accurately. If you say if a guy has mild intellectual disability, expressive language, oppositional defiant, ADHD, sure, it's harder to say than ASD, but it's more accurate. Scientists are splitters, not lumpers. Lumpers like to make the world easy and nice and compact, and that's not the way I was taught to think.
Great. Two more questions. So my son has ASD and ADHD. He is largely demanding, avoidant, and becomes aggressive when he is avoiding demands or during meltdowns. He is on guanfacine, and it helps, but I'm not sure it is the whole answer. He has a strong perseverating thoughts
Yeah.
and is anxious at times. Might a combo med be better?
Well, so that's a complicated picture, which is what we usually see. So he's got anxiety, he's avoidant, he's oppositional, he's aggressive. You kind of go to, well, what do you think the primary is? If you have anxiety, it could lead to all that other stuff. It kind of feels that way to me. And the drug treatment of anxiety, you've got safer drugs to try. So I would think you would be going after anxiety, maybe without seeing the patient, as a next step, and see what happens. If it's anxiety and the drug helps anxiety, those other things are going to kind of fall down like dominoes, if you see what I mean. But that's the way I would conceptualize that.
All right, last one. My son has schizophrenia and was prescribed Piodone. I also
Yeah.
know some adolescents and adults with ASD who were prescribed the same. All develop, oh God,
Gynecomastia. Yeah.
Thank you. Any thoughts on this?
Sure. Well, every antipsychotic drug except two, and I'll tell you, can increase prolactin in your body. And it's going to happen automatically. It's like, well, should I measure the level? No, it's going to be elevated. It just is. Well, your body thinks it's pregnant when your prolactin is elevated. Whether you're a man or a woman, your body thinks you're pregnant. So what happens when you're pregnant? Your breasts can enlarge, and you can have milk let down to feed the baby, right? And if you're not pregnant and your breasts enlarge and you got milk coming out, that's a scary thing for anybody, but probably especially if you're psychotic. So nobody wants that. So gynecomastia is the breast swelling, and galactorrhea is the milk coming down. And yeah, every antipsychotic except Abilify causes that. Abilify actually can reduce prolactin. So that's one thing to think about in your prescribing. Now, what do you do if they develop gynecomastia or galactorrhea? Well, that's not good. You probably say, I'm going to try to get the person off of this antipsychotic gradually and have that go away. But sometimes that's an issue. It's like, well, they're getting a lot worse now. They were on a drug that was helpful. What do I do? Well, you can't really put them on another antipsychotic other than Abilify. So you might then try Abilify to try to get, control of the psychosis or irritability and not have the prolactin elevation.
Sorry, I was muted again. That was the last question we had.
Chris, thanks so much. This was a great talk. And again, I apologize. They're building condos as they always are in Brantford, as you know, and it's caused hell. Anyway, this was a great talk and we appreciate it very much.
Thank you. Great to see you. Thanks, Eileen. Thanks for everybody. Please send me a couple emails, at least one about the Beatles. I'd appreciate it.
Those Beatles emails are going to come your way, Chris.
All right. Thank you.
Okay, bye-bye. Thanks.
Bye-bye.
Thank you, everyone.